Here we are again. What is all this? This is medical patient assessment in Kellyology. So first and foremost, life safety, scene safety. No matter what we do, whether it's a trauma patient, whether it's a medical patient, scene safety, personal safety is number one. So all calls, scene size up is first. First and foremost, your safety, your partner's safety, and the safety of those responding with you. So is the scene safe? PPE, BSI. Do you need additional resources? What's your initial impression of the scene? When you first come up, we see through the windshield, we see what's going on. What do we see? Is there anything dangerous? Any reason why we can't progress on into the scene? So that is what happens in the scene size up. PPE, BSI, how many patients do I have? What's a mechanism of injury? Do I need additional resources? And then finally, with life threats, C-spine. Do we need to take C-spine? So this is a medical patient, so we can assume we do not need to do C-spine. Now we're going to step into the primary survey. That begins with the, hey, are you okay? So we check for the LOC. What's the patient's level of consciousness? Are they conscious, alert, oriented? Are they alert to verbal stimuli? Are they alert to painful stimuli? Or are they completely unresponsive? That helps us determine the patient acuity. So, hey, are you okay? If the patient is unconscious, then we open an airway and check to see if they're breathing. These are life threats. We only address life threats here. So if the patient's airway is not open, we open it. If it's open but they're not breathing, then we open the airway and assist their ventilations. So airway, breathing, and then finally circulation. So are they breathing? Look, listen, and feel for chest rise and fall, listening for air to move in and out of their mouth, feeling if it blows on your face. That's airway and breathing. Circulation, you do a pulse check. Carotid pulse, radial pulse. Do them simultaneously. That will let you know a whole lot about the patient. If you have a carotid pulse and no radial pulse, then you can assume that the blood pressure is down or there's something going on that's causing the decreased pulses. So that's circulation. The final thing to go with this is bleeding. So in the circulation, we're going to add the bleeding in. Look for any life-threatening hemorrhaging. If they're bleeding anywhere, significantly fix that. All these things are life threats. When you find them, you have to fix them. That is it's the scene size up and primary survey. The last thing done in the primary survey is you determine the transport priority of the patient. If any of these things have a problem, that is a high priority patient. In trauma, we call it load and go. Medical, we can call it load and go. It's the same thing. We want to make a transport priority in that initial survey of the patient. So that's scene size up, primary survey. Then we move over into history taking. This is where we deviate slightly off from the trauma assessment. So in history taking, now we want to know what's going on. What's the history of present illness? You will hear that HPI, history of present illness. What is going on today? We want to do that through a sample history. We call it a sample history. SAMPLE. That's signs and symptoms, allergies, medications, past medical history, last meal, and events leading up to. All right, so let's go back to signs and symptoms. Signs and symptoms. Here's Kellyology for you. That's my horrible stop sign. Okay, stop sign. Okay, you can see a stop sign. That is what a sign is. Signs are things the patient that you can see with your own eyes, not things the patient tells you. Symptoms, things the patient tells you, but not necessarily something you can see. For example, if the patient says they are nauseated, that is a symptom. You can't see that, you can't confirm nor deny that. That is a symptom. If they throw up, they are vomiting. Vomit is a sign. Symptoms are something the patient tells you. So that's what we want to know. Signs and symptoms. Allergies, are they allergic to any medicines or anything like that? What medications do they take? What's their past medical history? When's the last time they've had something to eat? And then finally, what were the events that led up to this? What were you doing when this started? Did it just come on all of a sudden? Did you do something to cause this event to happen? What is the circumstances? So that's what the sample history is. Up here in the S, we branch over a little bit into O, P, Q, R, S, and T. These are the two acronyms that you will use the most because they're part of your patient assessment. O, P, Q, R, S, T is onset, provocation, also palliation, quality, radiation, severity, and time. So with signs and symptoms, let's assume the patient is a chest pain patient. So they're complaining of chest pain. Chest pain is a symptom. So onset, when did it start? What were you doing when it started? That's what onset is. What were you doing when it began? Provocation, palliation. Does anything make it better? Does anything make it worse? Kellyology, provocation, to provoke. Anything you do, make it worse. Anything you do, make it better. Palliation. Quality. Describe the pain. Can you describe the pain for me? Is it a sharp pain, dull pain, burning pain, aching pain? Feels like somebody cutting you with a knife, somebody stabbing you. Please explain how the pain feels. That's what quality is. Radiation means, does the pain go anywhere? Do you feel the pain anywhere else? So chest pain a lot of times is described as a pressure or something sitting on their chest. I feel like a ton of bricks on my chest. I feel like it's an elephant sitting on my chest. Does the pain go anywhere? Well, it radiates down into my left arm. It also goes up into my jaw. That is very common for cardiac heart attacks. So that's what radiation is. Does the pain go anywhere? Sometimes it'll go through to the back. That means something different. It'll go down one side. It may go down into the abdomen. We don't know. That's what the radiation is. Finally, severity, or not finally, but severity. Severity we deal with on a pain scale of 0 to 10. 10. 0 is no pain, and 10 is the worst you can imagine, or the worst you've ever had. Pain is very subjective, and unfortunately it's nothing that we can measure, so we have to take the patient's word for it. So no pain is 0, 10 is the worst pain you can imagine. That is severity. The last thing we do is time. How long has it been going on, and when did it start? So we want to know all of these things in the patient assessment. Signs and symptoms, followed with OPQRST, allergies, medications, past medical history, last meal, and events leading up. Finally, we want to get a set of vital signs. Okay? Vitals include skin, color, temperature, and texture, pulse, respirations, pupils, glucose, blood pressure. These are all vital signs. Skin, pulse, respirations, pupils, what's their glucose, what's the blood pressure, and then finally pulse ox. So put a pulse ox on them and see where their pulse oximetry is at this point. That is patient assessment at its baseline.